Hi everyone, so it's just after 1 o'clock, so we'll get started with today's webinar. So my name's Kirsty, I'm one of the tissue viability nurses at Coloplast. I've been here for 2.5 years and thank you for joining us today. So today's session is going to be based around wound preparation and the important role that Alprep Pad plays in that. So the objectives of today's session will introduce you to the 3-step approach, and we'll work through that in order to effectively assess and treat wounds, and we'll relate it to wound preparation. And sorry, doorbell's just gone and the dog's run out. So what we'll do is you'll learn a simplified approach to wound healing, understand the importance of wound preparation, and you'll get an overview of what the best practice recommendations say about wound preparation, including cleansing and debridement with the use of Alprep pads. And you'll leave with knowledge of the 3-step approach and the wound preparation pathway, which will help you support you in practice. So we know that the wound care landscape is changing. There is not one demographic that says that you can get a wound. Anyone can get a wound. As nurses, our workload is increasing and our workforce is decreasing. There's more nurses than ever leaving the profession. Funding is non-existent really when it comes to wound care, and even outside of wound care for other things, the funding's challenging. And there's more of a drive at the moment and more pressures for people to see patients in closer to home, in their own homes and in the community, than it is in a hospital or an acute setting. There is considerable resources that are attributed to managing wounds, and the graph that's on the screen in front of you just shows the cost that's associated with that. So the light blue is from 2012, 2013, and the dark turquoise is 2017 to 2018. So you can see the difference that's gone into the upscaling cost associated with where the wounds are being managed. So you can see there's a big push that more healthcare assistants are seeing wounds, and obviously district and community nurses compared to your hospital outpatients, even though there is an increase across all of them. It does say that evidence does suggest that approximately 60% of wounds are not being debrided frequently enough, thus causing delays in wound healing, having a negative impact on patients' quality of life, as well as incurring a significant health economic burden. So if you factor that into the graphs that I've just seen on the previous slide, if we can factor wound debridement and wound preparation into that, we could have real positive impacts on patients' quality of life, but also the health economic burden as well. So at Coloplast, we do have our 3-step approach, which is to step 1, assess, where you'd use holistic and wound assessment to define your treatment objectives. Step 2, which is what we're going to majority focus on today, which is wound preparation, which is key to removing barriers to healing and then creating that optimum healing environment. And then moving on to step 3, which you'd use your simplified portfolio of dressings to manage the wound, manage what you identified in your treatment objectives, and you can do that at any depth and any stage of healing. So when we're assessing our wounds, we need to identify the cause of why the skin broke down. We need to identify any associated risk factors. We need to correct and treat any underlying cause. So if you think of like your leg ulcers, for example, your venous leg ulcers, you're going to have to use compression to treat the underlying cause. You want to identify the appropriate management options, and that's for the wound itself, but also for the patient and what meets their needs and their lifestyle. You need to be controlling any wound-related symptoms, whether that's pain, malodor, exudate levels. You need to be preventing any further skin or wound deterioration. You also want to be identifying your patient's expectations, because some patients, and I've seen it myself in practice, have had these wounds for multiple years that they never see them healing. One patient of mine had had his wound since 2002, and he did say, he was like, I'm going to die with it, but if you can make it so I am not changing the dressing every day, that's what he wanted. And don't get me wrong, while I was still seeing him, we didn't get the wound to healing, but it did heal by 25%. It did reduce by 25%, and he went down from daily dressings to twice weekly dressings, but we identified his expectations so that he continued and continued with his care and was part of his own care. And you also want to be providing that psychosocial support and promoting patient independence with supported self-management where possible. The frequency that you would do your wound assessment will depend on obviously the condition of the patient and the condition of the wound, and also your care setting. So a holistic wound assessment, so your top to toe patient wound assessment, if you were in the acute setting, will be done every 2 weeks, and if you're in the community setting or primary care setting, it will be done every 4. For your wound assessment, you're probably doing it and you don't even realize you're doing it, but you will be doing it every dressing change, and it's just important that you document that on the appropriate systems or the appropriate paperwork that you've got. One of the best ways to assess your wounds and make sure that you've covered all areas and that provides that holistic wound assessment is the triangle of wound assessment. And it looks at the 3 areas of the wound, which is the wound bed, the wound edge, and the peri-wound skin, and it helps to support optimal clinical decision making, as well as factoring in what is needed for the wound. So if we break that down, you've got your wound bed assessment. So here you want to be looking at your tissue type. So you want to be looking for any necrotic tissue, any sloughy or granulating tissue, and any epithelializing tissue. You also want to be looking at your exudate levels. What is the volume of the exudate? Is it really dry? Do you need to moisten the wound up? Is the exudate levels low? So it would promote moist wound healing and that them cells move across. Is it medium or is it high? Is the wound drowning and is it going to cause some maceration to the wound edge and the peri-wound skin? Also, what's the consistency of the exudate levels? Is it thin and watery? Is it quite thick that it's going to cause a breeding ground for bacteria? And the colour can also tell you a lot as well in regards to kind of infection levels. On the discussion of infection, you want to be looking at your wound bed to see if there's any localized infection, such as increased pain, erythema, edema. Does it feel warm? The increased exudate can be an indicator that there's a wound infection there. Any delayed healing, friable granulation tissue. Is there any malodor and any pocketing? And then also your systemic or your spreading infection, which is that spreading erythema. Patient with a temperature, is there an abscess or pus starting to form? Is the wound breaking down? Any cellulitis? Are they starting to feel genuinely unwell? And is there things like a raised white blood cell count? Then you move on to your wound edge assessment. So for your wound edge, you want to be looking, is the wound edge macerated? Because that can indicate that the exudate levels aren't being managed accordingly. And then that wound edge is just going to break down further where the maceration is. Is there any undermining? Is the wound kind of going under on itself? And is the wound edge dehydrated? Again, is it going to need any moistening up so that the cells can move across to healing? And is there any rolled edges, which can be indicative of the chronicity of the wound, but also there might be something more malignant going on there as well. And then you want to look at your peri-wound assessment as well. So again, you want to be looking for maceration, which can be an indication for exudate levels. Any excoriation, again, that can be indicative of your exudate. It could be wrong dressing choice. It's also dry skin and hyperkeratosis to factor in. These are maceration, hyperkeratosis, next, but they're all dry skin is all a breeding ground for bioburden. So it's really important that when you are doing wound preparation, that you prepare the peri-wound skin as well to make sure you get rid of that and help protect the peri-wound skin. Like I said, you also want to be documenting all this. You want to make sure that your documentation is factual, relevant, consistent, and accurate. You want to include any positives and negatives that have come up in your wound, in not just your assessment, but your whole care episode. You need to be writing it as soon as possible after the event. It needs to be clearly written and it needs to be dated, accurately typed and signed. And obviously a lot of us now are using electronic patient records, so that's done automatically anyways, but just to obviously remember, if you are still using paper documentation, that needs to happen. And as we know, if we didn't write it, it didn't happen. So we're just covering our backs and protecting our patients as well, and ensuring that they're getting consistency in care. Once you've done your assessment, you want to confirm the action plan and the treatment objectives with your patient. You should be telling them what you're going to do, if there's any special investigations, what are they, why are you doing them, is there likely to be other people involved in that? Give them details of the specific treatment, let them know what's going to happen, how they might feel. I found with my patients that it was always best to let them know that there might be a little bit of discomfort initially with compression bandaging or compression hosiery, because they're aware of it, they're more likely to then comply and just see it out rather than taking it down. You can also let them know if you plan for them to do any supported self-management. So it might not be something that you'd be able to initiate straight away, but it's something that you can plant the seed and take them on that journey so that they can do it eventually. And also let them know what the plans for discharge are as well. So if you have a certain thing where you only see them to a certain point of healing, or if you'll see them through till healing, let them know so that they're aware. It's also really important to check with your patient that they understand the action plan, that they understand what's going on with their wound, and so that you can address any questions, any queries, and any concerns that the patient might have. Mentioned a few times now about supported self-management, and we should be, where we can, encouraging our patients to either share their care or self-manage where they're willing and able to do so safely. You can start by assessing your patient to see if they're fit for supported self-management from that first interaction that you have with them, and through providing a simple wound management plan, you are able to initiate that sooner. So, for example, if you're using just one dressing over so if you've got a silicone that can do conform to the wound bed rather than using a silicone foam with a filler, you'd be able to initiate that step a lot sooner. You want to be providing instructions on how they can care for the wound, how they can wash their hands appropriately. If it's an aseptic technique or a clean technique, give them the education on that. Teach them how to prepare the wounds, how to change it, and what they should be looking out for if there's any problems that should arise. So that's what we kind of do when we're covering our assessment. And what we'll do now is we'll move on to wound preparation, which will be the main focus of today's session. So it's not what we put on a wound that heals it, it's what we take off. And it's really important that wound preparation, that we are giving your wound that chance for optimal healing. It has been clinically proven that cleansing and debridement can speed up wound healing. The graph and the results that are on the screen in front of you now are from the Wilcox study, which was conducted in 2013. And they found that if you prepared a wound through cleansing and debridement, you had positive results and wound healing sped up as well. So the graph in front of you is based on the diabetic foot ulcer, and what they found was that if debridement happened a minimum of once every 2 weeks, the wound took on average 76 days to heal. Whereas if you debrided the wound once every week, that healing time went down to 21 days. So it had a significant impact on healing time. So if you think about, if we go back to the burden that's on the healthcare system at the moment, there'd be a decrease in cost associated with this as well, because you've got less dressings being used, less clinician time. It frees up your time because you're getting these patients off your caseload, but also the positive impacts it's going to have on your patients as well, because it'll give them positive influences on their quality of life. So these are things that we've probably all seen in our clinical practice when we're looking at wounds and we're trying to care for wounds. We've got excess fibrin and slough, we've got necrotic tissue and bacteria and hyperkeratosis. And all these things inhibit, one, your assessment, two, the wound healing, but it also affects your dressing and your product choice to help with that healing working effectively as well, because it's creating a barrier. Slough, non-viable tissue and biofilms all can delay wound healing process because they can increase the risk of infection. They inhibit the development of healthy tissue because healthy tissue just won't grow. And like I've just said on the previous slide, they limit your wound assessment. You're actually not fully seeing what's going on with the wound bed. Evidence suggests that 80% of non-healing wounds contain biofilms, and biofilms are a structured community of microorganisms with genetic diversity that creates chronic infection. They're characterised by their significant tolerance to antibiotics and antimicrobials while remaining protected from their host's defence. So you might not see a biofilm to the visible eye. Some nurses say that they think there's one there because the wounds have a shine to them almost. But your definitive ways to know if a biofilm is present is delayed wound healing, increased exudate or slough, increased inflammatory response, your erythema, your malodor, and your high bacterial load. So it's your signs of your local infection would indicate there's a biofilm present. The international best practice for the management of biofilms and infection, this comes from the International Wound Infection Institute. They say that the management of biofilms is not a one-step solution and different treatment strategies do need to be used. But step one, that what they say to get rid of biofilms and infection and reduce that risk, is to do wound preparation. So that would be to cleanse and debride, reducing the number of microorganisms because you're disturbing them and removing the biofilm. You would then apply your dressing and do infection management, but because you've disrupted that biofilm, the barrier dressing and any infection management techniques that you've put in place will be more effective and will keep that biofilm from forming back. But the first step, which is most important, is your wound preparation, and you can do that with Alprep Pad. So you don't want to just be preparing your wounds that have got an infection. You want to be preparing any wound, and any wound needs wound preparation, and that includes your ones that are at risk of infection, because your appropriate wound preparation and management can reduce the likelihood of wound infections developing, because you're removing and you're staying on top of that bacterial burden. You're giving the products that you're using the best chance of working on the wound. Through wound preparation, you're removing them barriers, which may delay healing. You can prevent the formation of biofilm, reducing the bacterial burden, which then stops the microorganisms from multiplying and moving deeper into the wound bed. Wounds should be prepared at every dressing change, because the aim of wound preparation is to accelerate healing and to, like I've been saying, facilitate the effectiveness and the management of them treatment plans. But that is also based off your assessment, your own clinical judgment, treatment goals, and obviously patient pain levels as well. But regardless, it needs to be routine and it needs to be regular. The more frequent the debridement sessions and the wound preparation, the better the healing and the quicker the healing. So when we're talking about debridement, there are different forms of debridement. You've got your autolytic, you've got your biological, enzymatic, mechanical, and your sharp debridement. So this is just from the best practice recommendations on that was produced in 2002. And it just breaks down what them different types of debridement are. So the box in the green is your washing and cleansing. So this is just your washing the surrounding skin to maintain the healthy environment, stop any further complications, loosening any surface contaminants, debris or bacteria that may be on there. And that can be done by anybody. It does not need any additional competencies or training. When you get down to your debridement, so you've got, remember off the slide before, you've got your autolytic, your mechanical, your biological, and your enzymatic. These types of debridement don't necessarily require extended competencies and training, but you do need some knowledge and skills, especially around the products that are being used and the way that they are working. So autolytic debridement is your body's attempt to shed any devitalized tissue through moisture. So you can do this through moist wound healing and through a dressing that creates that moist wound environment. So such as your biotin silicone, your silicone foam dressing. Then you've got your mechanical debridement. So this is the physical removal of any devitalized tissue using friction. And this is where Alprep Pad sits. So you can use Alprep Pad to facilitate your mechanical debridement. Then you move down, you've got your biological debridement, which is your use of maggots, which isn't seen as much, but they do have a place. And then you've got your enzymatic debridement, which is where you'd use your gel that would contain enzymes that soften and lift necrotic tissue. And then the last form of debridement is your sharp or your surgical debridement. So this is obviously using scalpel, forceps, a curette or scissors to remove any devitalized tissue. Your sharp debridement might, but doesn't always, need some local anaesthetic, but your surgical debridement will definitely need general anaesthetic, and that will need to be in theatre. And this, for any form of sharp or surgical debridement, you do need that extended skill and your competencies, and it does require extra training. So if you feel that that's required, you need to refer on to your specialists that are trained and competent to do that. So there are times that we need to be cautious with wound preparation. So these are if a patient has a wound on the lower limb and is known to be a diabetic, you're best off referring on to your specialists in this area. If they've got a known arterial concern or poor localised tissue perfusion, if their healing ability is impaired because of medications or an underlying medical condition, you'd also be cautious if you thought the wound was malignant, and if there was any tendon exposed or any bone. So research has previously shown that there are challenges when it comes to mechanical debridement. It could be limited functionality or unintended. It was unintended for debridement, so that it wasn't used for that reason. The debridement product, the mechanical debridement product that's being used didn't absorb, so it might disrupt and it might remove debris, bacteria, slough, but it would leave it in the wound bed, so you then needed to use something else to get it out. And then there was also a lack of usage control. And I used to have it when I worked quite in practice. I've obviously used other products that if you've been using them on hypertotic legs, after a while your fingers really do start to ache and hurt. So something needed to be a little bit more ergonomically designed, and that's where Alprep Pad came in. And now what I'm going to do is I'm just going to hand you over to Shanaz, who is going to talk to you about Alprep Pad. Over to you, Shanaz.
Thank you, Kirsty. Good afternoon, everyone. My name is Shanaz. I'm Senior Territory Manager within Coloplast Wound Care in the South East. So I'm just going to spend a few moments just talking to you a bit more in detail about Alprep Pad. So this is a 2-in-1 cleansing and debridement tool, and it's been designed to make life a lot easier for yourselves as clinicians and also potentially for your patients as well. So you've got the dark grey side, which helps to break down and loosen the devitalised tissue and break down the biofilms. And you've got the lighter grey side, which is more absorbent and has a unique slits to capture that loosened debris and biofilm and remove it from the wound bed. And the shape has been designed to help get into some of those slightly tricky areas. So what I'm going to do is I'm going to come onto camera, we'll stop sharing the slides and come onto camera and give you a demonstration of how to use Alprep Pad. So thank you. Okay, so I'm just going to turn my camera down to my desk because I've got a model here and I just want to show you a demonstration of it used in practice. So we've got a model here that has obviously a wound, sort of what a typical pressure, grade 4 pressure ulcer may look like. Obviously, just a disclaimer that you may see obviously some bone structures in here, but as Kirsty has alluded to, please do be cautious when it comes to debriding with underlying structures visible. So the Alprep Pad come in an individual pots like this. So come in a box of 5 and they are individually wrapped in a little pot like this. Now you can use these pots to put your irrigation fluid, so whether that's water or saline, you can pop them in this pot, or you can use a normal method that you normally use. So this is what they look like. So you've got the dark grey side that I mentioned earlier on to help break down the devitalised tissue and some of that stubborn slough, and also the surrounding skin, so the hyperkeratosis and surrounding skin. And the light grey side has these unique slits that will capture all of that loosened debris to remove it from the wound bed. When it comes to using it, I'm just going to do a little demonstration just to make it a little bit realistic. So I'm just going to put a little bit of glue in the wound bed. So obviously when you remove a dressing, you may have slough, exudate in the wound bed itself. So just for demonstration, just going to pop a few of those in there just so you can see what it looks like when it absorbs. Now, before using the Alprep Pad, you must get it wet. So I've just got a bowl of water here. So again, obviously, depending on your setting, whether that's in the little pot that it comes in or a separate bowl, or if it's for leg ulcers in the bucket. So once you get it nice and wet, just squeeze out the excess and just start by, again, this depends on the actual wound itself. So if there is fluid in the wound bed, you can just use a light grey side to sort of absorb that before you start cleansing the wound. And you can rinse the Alprep pad in the bucket as you go along to remove the debris. So to start breaking down and removing some of that biofilm and stuff, you just basically use circular motion. So just spend time on the area that you need to remove that slough and the biofilm. Now, this wound has also got some undermining here as well. And what you can do is pinch the tip to kind of get into some of those slightly tricky areas. So it is designed to be quite ergonomic for those areas. And it's not just the wound bed itself, it's also the surrounding skin. So you want to remove the devitalized tissue and the biofilms from the edges and the surrounding skin as well. So you can spend time just going in circular motions, and you will see as you're cleansing, the devitalized tissue starts to break down and loosen and starts to come away from the wound bed. And once you've done the sort of breaking down of and loosening of that devitalized tissue, use a light grey side to wipe away. And as I mentioned, the slits will capture that debris from the actual wound bed itself and remove it. So we'll trap it into the Alprep pad and remove it from the wound bed itself. So that's a quick demonstration of the Alprep pad itself. So we do have a few images just to show you some example of where it's been used on some wounds, some before and after pictures. So these are various different wounds. So Kirsty, I don't know if you want to just share a few slides with the images so we can show. Thank you. So we've got here a few different wound types. So we've got a diabetic foot ulcer and some venous leg ulcers. So you will see from these images some examples of what the wound can look like before cleansing and after cleansing. So on the next slide, you'll see the diabetic foot ulcer. So you can notice here that on the before picture, there's devitalized tissue. So there's slough in the wound bed and the wound edges as well. You've got some maceration as well. But after a thorough cleanse, you can see that there's a clear improvement in that wound bed itself. So that's going to respond a lot better to the dressing that's then applied. So the patient didn't experience obviously much pain with this particular wound, which you may find with diabetic foot ulcers due to neuropathy, but generally it is very well tolerated. So this before and after is after just one dressing change, so one cleansing session before and after. On the next one, you'll see an example of the Alprep pad being used. So on this patient, this is an example of how to use, so a demonstration. So you can see here that the clinician is using the dark grey side, using circular motions and just spending time to break down that slough and devitalized tissue to get it nice and loose. And then to finish off, using the light grey side to wipe over, and that captures all of that loosened debris, that dead skin, all into the actual pad itself. And that reveals a nice, much cleaner wound bed ready to then dress. So on the next one, there's a patient with a leg ulcer. So again, this wound needed to be prepared to be able to support the assessment as well. So as Kirsty mentioned earlier on, it's really important to remove that devitalized tissue so we can actually see what's going on in the wound bed, and it helps us to assess and document more accurately. So again, you can see here a marked improvement in the actual wound bed itself with just one cleansing session. And the next slide, you can see also there's another example of clear improvement. So you can see quite a bit of buildup of slough on this wound bed itself, but using the Alprep pad, being able to cleanse and remove a lot of that devitalized tissue and a lot of that slough meant that the dressing can then help that wound healing process much better. So that's an introduction to Alprep pad. Hopefully that gives you a good insight and some hints and tips on how to use it effectively. You can use it on various different wound types, but again, obviously do follow your local guidelines as well. I think that's it from me. So I'll hand back to you, Kirsty, to carry on for the rest.
Yes. So as you can see from the photos and from the demonstration that Shanaz has given, Alprep pad is really simple and it's really easy to use, and it does help support self-management because patients can use it themselves. I've had it in my practice where I have given patients their own to do supported self-management with, and they really do love it to the point where they will come back into practice and tell you how much they collected on the pad. And they do get really, really involved. So like we said at Colopass, we've got our 3-step approach. So we've done assessment, we've assessed the wound, we've made sure it's appropriate for wound preparation. We've gone through the benefits of wound preparation, and Shanaz has shown you a demonstration there of Alprep Pad, and then there's treat. So as we said, one of the things with wound preparation is that when it comes to your treat, you're giving your product the best chance it has of working. And through wound preparation, you're also creating that optimum healing environment for the wound. So once you have done your wound assessment and your wound preparation, you then want to be looking at what your treatment options are. So you really want to be factoring in your exudate. Do you need to be managing that? Do you want to be protecting that peri-wound skin? Do you need to be looking at and rectifying any maceration or excoriation? Is there any depth or cavity to the wound that you need to be thinking of? And like if we revert back to the best practice as well, is there any infection or biofilm that you need to be aware of? But remember, identifying and treating any underlying cause is integral, because you could heal the wound, but if you haven't treated that underlying cause, the wound's just going to break down and just going to come back, and it'll just end up being a vicious cycle. So at Colopass, we do like to make life easier for patients, for you guys as healthcare professionals. So this is why we've developed the 3-step approach, to give you a simplified approach to wound healing. It's 3 steps. It's simple to follow. You can follow it. The patients can follow it. They can assess their own wounds, prepare their own wounds, and treat their own wounds following your holistic assessment and your treatment plan. And this is just some case studies of where the 3-step approach has been utilised in practice. So this is Mr. H. He was a 90-year-old male with no comorbidities, which is just incredible at 90. I think I've got more of a quarter of his age, but he had a mixed etiology leg ulcer, and it had been present for more than 10 years. His ABPI was outside the normal parameters, and therefore he was not suitable for a full compression. Due to this wound, he'd not been confident with travel. As you can imagine, having a wound and going, if you're trying to get on a plane, it's hard enough as it is with having to factor in a wound and all the things that might go with it. So on the wound assessment, we were wanting to create the optimal healing environment. So they wanted to remove any non-viable tissue. If you can see on that first one on day 1, you can see there is some slough there. There looks like there's some crusting of exudate on the wound edge as well. So they wanted to also manage exudate. The wound had been present for more than 10 years, so it's safe to say that there will probably be, most likely, a biofilm there. So you want to be managing the bacterial burden as well. There is some epithelial and granulation tissue there, so you want to be protecting that, and you also want to be protecting the skin, because if the one, based on his age, 2, the length of the wound, and the fact that this leg and this wound's going to be in dressings for multiple years, you want to be protecting that, any healthy skin that is there. So that was the management goals based on the assessment. So they then used Alprep Pad to do wound preparation, and the treat option was biotin AG non-adhesive, and that was purely because of the organisations wanting not to use the silicone under compression, but biotin silicone and biotin AG, they're safe to use under compression. So you can see the progression in this wound from day 1 to day 3 alone. You can see that non-viable tissues lifted, the crustiness from the exudate is not around the wound edge. The wound just looks generally healthier in general. And this wound went on to heal by day 54. So over more than 10 years, this patient had the wound, had been various episodes of care from healthcare professionals. At first, he did found the wound preparation was painful to tolerate, but he did. But once Alprep Pad was introduced, he could tolerate it better, and his wound, as you can see, made visible and significant progress. He was able, and due to his ABPI, go into 10 milligrams of mercury compression, whereas before he wasn't in anything because of the level of pain and exudate that was coming from the wound. He was eventually able to step down to biotin silicone and compression hosiery and share his care and do supported self-management. And as I said, the wound went on to heal in 54 days. So imagine living with a wound for 10 years to then have it heal in less than 2 months, purely by following prepare with Alprep Pad and treat using a product from the Biotin range. And then this is another case study of Mr. D. So this was a 55-year-old male who had his big toe amputated due to type 2 diabetes and arterial insufficiency. He had multiple dressings, daily dressing changes due to the high exudate levels. So the assessment here identified that obviously we need to remove any non-viable tissue. You can see the slough there in the wound bed at the top. You need to manage the exudate levels. You can even see the shine coming from the exudate that's just coming from the wound just on the photo. And if he was having daily dressing changes, you can imagine how wet this wound was getting. He had obviously the bacterial bioburden. If he's had that much exudate coming from the wound, there's an indication there that the bioburden is probably a local infection there. So that needed to be managed. There is some elements, and you can see at the top left of the wound of some granulation tissue at the wound edge that needed to be protected. And you just want to protect the overall skin as well, because you don't want this wound to break down any further. So again, this wound was prepared using Alprep Pad, and Biotin Silicon AG was used as a treatment option. And you can just see the difference between week 1 and week 9 to this wound. The wound decreased from 18 centimetres by 7 centimetres down to 4 centimetres by 1 centimetre in 14 weeks. So that's a huge, huge difference. The top of the wound where the toe was fully healed. It was just obviously down the side of the foot that was left to go. Exudate levels to the remaining open area of the wound were low, and as you can see from the picture, there is no signs of any local infection there, and the patient's pain score was a 2 out of 10 at this point. The wound at the point of this case study being pulled together no longer required any antimicrobials to manage the bacterial burden, and it was being treated with Biotin Silicon. So just another example of how wound preparation and the right treatment choice can really promote wound healing. So another thing we like to do to make things simple at Colopass is develop pathways for you to follow. So this is our wound preparation pathway. You can see it starts at the top with assess, with your triangle of wound assessment, which is obviously the wound bed, the wound edge, and the peri-wound skin. So you'd complete your holistic patient assessment and your wound assessment. You'd then identify any red flags. You'd then move down onto your prepare section, where you would wound cleansing and wound preparation using Alprep Pad. You'd then go down to your treat, where depending on what you identified, you would then use your simplified portfolio of dressings, and then obviously you'd reassess, and background it goes until healing. And then on the back of our pathways, what we do is we provide you a simplified product selection guide. So obviously you've got your step 1, you assess. Step 2, using Alprep Pad to prepare. Step 3 is your treat option. So for your superficially low exuding wounds, you've got your Biotin Silicon Light. Your wounds with up to 2 centimetres in depth, we've got Biotin Silicon because it offers that 3D fit technology and conforms to the wound bed. Any wounds deeper than that or have any undermining, we've got our Biotin fibre range, which either can then use Biotin Silicon as your secondary dressing. And also for your infected wounds, you've got your Biotin Silicon AG and your Biotin AG non-adhesive. So that's everything from us today. Has anyone got any questions?
There's a few questions in the chat, Kirsty. I don't know if you
Yeah, I've just seen that. There's quite a few actually. So Sam's answered one for us. No, the pad is not medicated, it's just a physical mode, as Sam says. Any evidence to show it will not hurt on new granulation tissue? I've used this in practice for multiple years, and you find that it's more the bioburden and the patients that have got the wound infection that they tend to be the ones that it hurts more for than the new granulation tissue. Any more questions? The pad is single use only. It does go on formularies as well, so you'd have to check in your local area. How many in a pack? There's 5 in a pack. They are single use, and Shanaz showed you. You just pull it from its little dish. How much would depend on your supply route as well. So unfortunately, I can't answer that one. Does it need permission from use from district nurses? I think that would depend on what your local policy is in regards to wound care and who initiates treatment. That one you'd have to take up locally. Oh, you've answered that one, Shanaz. Sorry, thank you. Can you use this into a nursing home? I think it would depend on what your local policy is for wound care in a nursing home. I know up here in the northeast, the nurses can do it themselves. It would just depend on what's obviously on your local formulary. Thank you, Sam. You've answered that one. Do you see any adverse reactions while in use? No, not seen any adverse reactions while I've used it. Like I say, you use it for the best practice is to use it between 2 and 4 minutes. I have had it before where patients, because of the bioburden, they've not been able to use it for 2 minutes, but you can build up, and surely enough, you get them patients that are like, no, you need to go longer, not enough to come off the wound. So yeah, but that's about it. There's no adverse reactions. The pad is sterile when it comes out of the pack. You will get a certificate. Has the product been compared to other similar products such as Debra Soft? I do know that there are some areas up in Scotland that have been comparing it, and there has been some work from Manchester University where they have compared it, and hopefully we'll get them results soon. But preliminary in vitro studies show that Alprep Pad did remove biofilm better than gauze and other products in the in vitro early studies. Has anyone got any more questions? I think that's everything in the chat.
I think there was just
Gabrielle.
1 or 2 in the Q&A.
Does the wound still bleed when you're using the pad? So sometimes it can bleed, and that would depend on where it's at in the infection continuum. If there's bioburden, because obviously it could indicate that obviously the granulation tissue is friable, so it can bleed. After that, you don't see it a lot once the bioburden's kind of gone down. So yeah, that's it. And then we've just got somebody asking about details. Did you say some in the question and answers? So Laura's asked, is there any advantage to soaking the pad in Prontazan fluid, for example, to break down the biofilm, or using the Alprep pad after a Prontazan soak? So we back in May, June time last year, we published our 3-step approach evaluation, where we had results from 60 patients who had utilised the 3-step approach. Then results showed accelerated healing. Patients who had wounds for, on average, over 70 odd weeks went on to heal in just over 6, and none of them used antibiotics while they were part of the evaluation, and none of them used any surfactant, including Prontazan. So that research, that evaluation that we did, showed that there wasn't an advantage to soak it. It's not work that obviously we have done at the moment, but I found personally in practice that I didn't actually need to use it. Is there any, again, Laura, is there any evidence for frequency of wound reviews by an RM, please? Again, Laura, that's based off your individual assessment. I don't think there is any referencing out there regarding that. I think it all just goes down on, like you've said in your question, on skill mix, workload planning, things like that. It really does come down to your individual assessment. Has anyone got any further questions? I hope I've answered the ones that you have put in the chat. I must admit, you guys are really good. I think these are the most questions I've had on any one of the webinars I've done. Well, if no one's got any questions, we'll end it there. Thank you everyone for your questions. Thank you for listening. Thank you for taking part. We will send out some things out to you. Sorry, there's what without using any solution for cleansing Alprep Pad will do. Yeah, so you just need to. We have found that just using Alprep Pad with saline or water will do and will remove some of the debris and the bioburden. But yeah, thank you everybody. The slides and certificate and the pathway will be sent out to you. So thank you very much and enjoy the rest of your day.